All right, well, hello, everyone. My name is Dr. Channing Burks Chatmon, and I am the newest physician to join the FCI team, which I am extremely excited about. Just a little bit about me before we get started. So I grew up in the Midwest in Indiana and did a lot of my training in Chicago, so was very excited to come back after my infertility fellowship. And so today we just wanted to, in honor of National Infertility Awareness Week, we are trying to do a lot of educational webinars just to kind of help to educate, raise awareness, promote just the fact of how common infertility is, and also increase conversations in order to normalize the fact that infertility is so common. So we are going to get started, talk all things infertility, and at the end, I will answer your questions. Okay, so as I just mentioned, I'm Channing Burks Chatmon, and our topic today is Fertility 101. So just a little bit before we get started about FCI, or Fertility Centers of Illinois, we currently have 11 physicians in our practice, and we have 8 locations that are located throughout the Chicagoland area. And I think one of the advantages of that for FCI is the fact that we have locations that hopefully will be convenient to you physically, but also we are offering virtual appointments. So if you physically would like to come in, you can, but also we can see you virtually. And that, I think, just makes it easier to get in, and also to hopefully see a particular doctor that you might be interested in seeing, even if they're not physically close to you. And it's also helpful for monitoring. So anytime you come in for an ultrasound or for lab work, you can go to any location. So let's say you work in one location and live physically in another, you can go to whatever location is convenient for you, but your doctor will still get those results through our electronic medical record system. So I definitely think that's an advantage. FCI has been doing this for a long time now. So we have over 35 years of experience and over 40,000 babies that we have helped bring into the world, which is really a large number. And as far as IVF procedures specifically, we do more than any practice in the Midwest. So you can kind of just rest assured that your eggs and your embryos are in good hands with us. So infertility, it is very common. It is defined as the inability to conceive after 12 months of unprotected intercourse if you are under the age of 35. Or we consider if our female partner is, sorry, just trying to change the view of my screen, bear with me 1 second. If the female partner is 35 years or older, then we would advise for you to have a workup at that time. But it's also important to note, if your OBGYN or even a primary care doctor has let you know that you have a medical condition or some aspect of your medical history that might affect fertility, then it might be best for you to come see us sooner rather than later. And as I said, 1 in 8 couples do experience difficulty conceiving. So 1 in 8 couples are impacted by fertility issues. So when you think about that, even though many people are not open about the fact that they might have infertility or are undergoing fertility treatments, the odds really are that someone that you know, probably even someone that you're close with, whether it be a friend or a family member, a coworker, has experienced difficulty conceiving. So you definitely are not alone. So 33% of Americans report that they know someone that has used some type of fertility treatment. 48% of women are unaware, unfortunately, that fertility rates do decline between the ages of 30 and 45. And 52% of women reported that over the age of 35, they would have made different decisions in regard to their fertility if they had had better education as it pertains to fertility when they were younger. So when undergoing an evaluation for infertility, when we are looking at all the factors that are involved, typically what we find is that a third of the time we find a factor that might be related to our female partner. A third of the time, so equal amount, we find a factor related to our male, so something associated with their sperm. And then the final third is either we find a factor from both partners in the couple are contributing, or that all the testing comes back normal and you have what's called unexplained infertility. So it doesn't mean that you don't have infertility. It just means that we still honestly have a lot to learn in the field, but we do have known treatments for patients who fall under that group. Other just common causes that fall into these categories are PCOS or polycystic ovarian syndrome, endometriosis, diminished or low ovarian reserve, fallopian tube damage or blockage, which can occur for many different reasons, recurrent pregnancy loss, which actually is kind of considered a separate condition from infertility, but some couples are affected by both. So they have trouble conceiving, which is infertility, and they also unfortunately have had difficulty maintaining a pregnancy or getting to their goal of a live birth. Abnormal sperm production or function, that's typically obviously our male factor, and then secondary infertility, meaning you've had a live birth, and then now when you're trying for your second or your third child, unfortunately you're having trouble conceiving, or unexplained fertility, which I previously explained. So some factors that can impact fertility, we know the number one factor that impacts fertility and likelihood for success with treatment is age. So it is the number one factor. Other important things can be weight. So we do know that women that are overweight or obese, which is a BMI greater than 30, and that's kind of a number that's based on your specific height and weight, can have difficulty conceiving, and also can be at increased risk for miscarriage. We definitely do know that smoking can have a negative impact. It mostly affects the tubes, which are responsible for picking up the egg at the time of ovulation, and then the egg and the sperm meet in the tube, and that's where fertilization occurs. So the tubes are very important, and we know that smoking can adversely affect tubal function. Drinking alcohol in excess can also impact your fertility or chances of conceiving. And then kind of just minimal physical activity just really also relates to the weight. There are certain medical conditions that can impact fertility, sometimes autoimmune diseases, endometriosis. So if a doctor has ever told you, you know, down the road when you're trying to conceive, if you're having difficulty, you should see, you know, a specialist, then you should come and see us earlier rather than later. So I think this is a topic that a lot of patients want to know. Should I start with my OBGYN or should I start with my fertility specialist? So I think what's most common is patients, because you have that established relationship with your OBGYN, you know, will discuss with them, I'm trying to have a baby, and they will encourage you to try, you know, talk to you about ways to optimize natural conception. But really, once you're hitting that kind of 6 to 12 month mark, depending on your age, so 35, 6 months, less than 35, 12 months of trying, you know, it really might be time to come and see us. And, you know, as a fertility practice, we are focused on just purely diagnosing and treating infertility. And our workup, because that's our only focus, thus can take less time to complete. We also will have a dedicated team member, nurse, that will help you through all the logistics of your testing and how to get it done, you know, in the most timely fashion. Because we do understand that you've already been trying to conceive for a certain period of time and you're ready to be pregnant and to have a baby. And we do also offer or have the ability to offer options that, you know, some OBGYNs are not able to offer. So besides just ovulation induction agents, which a lot of OBGYNs do feel comfortable providing, such as Clomid or Letrozole, and some may not, we can offer in addition to that an IUI. And then obviously we have the ability to do IVF, which your OBGYN just does not have the capacity to do because they're doing so many other things. So who comes to see us? So it really varies. We see anyone who is trying to build or expand their family. So that includes heterosexual couples, so women less than 35 who've been trying to conceive for 12 months or more, women that are greater than 35 that have been trying to conceive for 6 months. If you have a known or suspected cause of infertility that's been previously diagnosed, we treat and see same-sex couples, single parents, and also transgender couples. We also see patients that are seeking to preserve their fertility. So they can do this for elective reasons. Maybe they have not quite yet found the partner that they know that they are looking to build a family with, or because they're focusing on their career. We also see patients that have a medical condition, such as potentially cancer, that are looking to preserve their fertility before they undergo treatment for that cancer. And then we also do see oocyte donors that are willing to donate their eggs to families who are looking to need an egg source to help build their family. So what happens at your first appointment? So you will, you'll come in, you'll check in, and then you will just meet with your physician, and you'll just, that's your time to share what you and your partner, or what you have been doing on your own to try to conceive, any treatments that you have already undergone, any medical history that's pertinent. So we'll want to know all about your medical background, your surgical history. When we say social issues, so are you a smoker? How much alcohol do you drink? Are you able to get exercise in? And then it's also really important to talk about your family history. We will review any prior fertility testing that you've done. It is always helpful. I think if you are able to kind of bring those records with you, it's not obviously a huge deal, but it does kind of streamline the process a little bit if you're able to get your testing from your OB/GYN and then bring it with you to your first appointment, so we can go over it together, and then we will scan it into your record. And that also helps us to not repeat testing if you've already started the process. I have a lot of patients that will just pull it up on their phone. They will be able to access it through their portal, through their OB/GYN, and we just go through it that way as well. That's a time for you to ask any questions that you might have, to have any concerns addressed. And then we will just talk about the fertility evaluation. So what testing are we going to do? And then at that appointment, we'll talk about the evaluation. Then typically you'll go off to do the testing, which typically takes 1 to 2 months to complete. Really depends on where you are in your cycle, but oftentimes we can get it done within 4 to 6 weeks. And then you'll make an appointment to come back, discuss your results, and then come up with an individualized treatment plan that's right for you. So what is common in an infertility evaluation? So I'd like to kind of group it in different categories. So first, let's talk about ovarian reserve testing. So this is something that is done early on in your cycle, typically cycle day 2, 3, or 4. Cycle day number 1 would be the first day of your period. So it is composed of an ultrasound, where we do a transvaginal ultrasound, and we are actually looking directly at your ovaries to see how many tiny follicles or potential eggs you have on each side. That helps us to know what treatment might be, right for you, and also helps us to predict how you'll respond to treatment. We also, at that same visit, would draw blood that would also look at kind of your ovarian reserve. So that's an FSH, estradiol, and anti-Müllerian hormone, which most people abbreviate as AMH. We'll also do other blood tests to look for hormonal imbalances. So this typically is going to be thyroid tests and prolactin tests. And then also, if you are concerned about any other hormonal issues, such as increased hair growth or acne, or you're having irregular periods, then your doctor is likely going to order blood tests for polycystic ovary syndrome to see if you meet criteria for that diagnosis. A little bit later in your cycle, so now days 6 through 11, when you've completed your bleeding, we want to do a structural assessment. So looking at the uterus to see, is there anything inside the uterus that can potentially impact your ability to conceive or to get pregnant or stay pregnant. So these could be things, fibroids, polyps that a woman can develop throughout their lifetime, or it could be a structural defect that you were born with and just might not ever have known because you don't have any symptoms of it. And then also at that time, we will assess the fallopian tubes to make sure that they are open, because it is their, job or responsibility to kind of retrieve that egg when you ovulate, and then that's where it will meet the sperm for fertilization. And then for our male partners, we will do a semen analysis. We want to know, is the sperm normal in number? Is it also normal in its movement? So sperm has to be able to travel at the time of intercourse to meet the egg in the tube. So we need to make sure it has progressive movement. So after your testing is done, you will sit back down with your physician. You'll go over all the results. And then you'll talk about all the available treatments. So what we can offer is intrauterine insemination, IUI. That is typically something that is paired with an ovulation induction agent. Those help, can help to have a stronger ovulation, or also to help you ovulate regularly if you have any ovulatory dysfunction or you're not having normal menstrual cycles. Another option is in vitro fertilization. So this is a more invasive treatment option. This is when you take subcutaneous fertility injections. So they're man-made versions of hormones that you already have in your body. And we are kind of helping your egg to grow all those tiny follicles in your ovary that would otherwise go unused. Because typically in a normal menstrual cycle, you'll have one egg that grows to be that egg of the month or MVP, and it will ovulate. In an IVF cycle, we're trying to force all of the little follicles there that are there at the beginning to grow into those larger follicles or the MVPs. Egg freezing is an option. So it's essentially the same as IVF. You're going to take fertility injections, and then we're going to grow the follicles to hopefully produce eggs that can be frozen so that you can use them in the future. Frozen embryo transfer is when now we have an embryo. So egg and sperm have been created, fertilized in the lab to create an embryo, and then we transfer that embryo back into the uterus. So this is something that you, it's similar to a pap smear. You're not asleep for it. And it is something that we can time, whenever it is convenient for your life and for your schedule. We also do have a third-party team, which is another, I think, real strength of our practice, where we have a sole nursing team that helps to coordinate anyone that is using donor egg or donor sperm, because there can be a lot more requirements from the FDA when we're having a third party or source, either of egg and sperm involved. So they're there to help streamline that process for you. And then we also can help you if you are looking for or are in need of a gestational carrier or a surrogate to carry your pregnancy. So insurance coverage is a tricky thing, but one really good thing about Illinois is that it is a mandated state for fertility coverage. And it really is a blessing because it's rare. There's only a handful of states in the United States that have mandated coverage for fertility. And, as a fertility doctor and someone who's passionate about fertility awareness, this is something that we're all kind of banding together to change. But right now, it is just not so. And Illinois, we're just lucky that Illinois has mandated coverage. So not all employees in Illinois will have an Illinois-based insurance. So if that's the case, then you unfortunately might not have coverage. But also, even if you do have coverage, it can differ. So different employers can offer different plans. You could have a plan that could cover diagnosis only and not treatment. And there's also different types of fertility, fertility coverage. So one thing we try to do is after you see us or right before you see us, we kind of want to know what your plan is so that we can let you know what's covered, what's not covered, because we just don't want to have any surprises. And we know that this is something that, financially you might need to plan for. And so we want to be very aware of that and help you with that. And then, as you can see listed here are the insurance providers that we currently do accept. So financial options, again, so if you're paying out of pocket, we know that this can be a very expensive journey. You will be assigned a financial coordinator. Every FCI physician has a designated financial coordinator to help their patients. So they will go through, figure out what your insurance policy covers, and then kind of let you know, okay, IUI is covered, but IVF is not. Or IUI and IVF is covered, and also let you know if there's a maximum that you're allowed to do, 4 cycles of IVF a year. That can be a typical plan. Or some insurance programs or policies will give you a lifetime maximum. So they'll say you have, 15 or 20,000 of lifetime dollars that can be attributed toward fertility. So for those that unfortunately don't have coverage or don't have treatment coverage, there are different grants, there are different plans that we can help you with, and that's another thing our financial coordinator can help you with. And also costs for medications, there's different ways, different grants and funds, so we can try to help make it a more affordable process. FCI, we really want to support you in this journey any way that we can, but I think one of our best resources is the fact that we do have dedicated reproductive counselors that you can see, and they also do see patients virtually. Just if you are struggling with, the stress and the anxiety that comes along with fertility and trying to build a family, that is very common. So, we really encourage you to use them, because, that's what they do. They really want to be there to help you. If you've had pregnancy losses, that can come along with such, such grief and, just sadness, and also then anxiety surrounding your upcoming pregnancy. So again, that's another great resource. We do also have support groups that I think, our patients, once even if they're timid to start, once they start going, they really do enjoy it. And then community-wise, we do try to share patient stories, on our social media accounts, just so that you can see, that other people have gone through very similar things that you might also be going through. And then, of course, we want to try to raise awareness or education. So that's why we, you'll see that the FCI physicians, we really try to do webinars and blogs, just so we can make sure we're doing our job to help get the information out. So what's next? So if you are ready to take that first step and, come in to see us, and we would love to have you, you can see listed here, this is our new patient call center number, and we have a dedicated person that can help you to set up a in-person visit or a telemedicine visit. So whatever is convenient for you. And I do think, I will say, if you are concerned that maybe your partner can't attend, or you guys are, both can't get off of work, or you're just physically in different areas of Chicago or the suburbs, telemedicine can really be helpful with that, because we can include everybody at the visit, and it's just a little bit more feasible that way. For more information, please visit our website, fcionline.com. And then also, you're always welcome to follow us on Instagram and Facebook, and you can see there's our social media account. So Fertility Centers of Illinois, and then mine is Channing Burks Chatmon, MD. So I think we have reached the question portion of our webinar today. So let me just change the view of my screen so I can answer your questions. Let me log into the chat. Okay. So this is a great question. So someone asked, how much caffeine can I drink when undergoing fertility treatment? So One thing that a lot of people have heard or they're told is that when you're trying to conceive or when you're pregnant, you cannot have any caffeine. And that is not true. We don't want to say that you can't have any caffeine at all. We just want you to have it in moderation. So really that would be one caffeinated beverage a day. And I would say anything that's 200 milligrams or less is the recommendation. So I would say that's more like a tall or a grande, not necessarily a venti at Starbucks, but at least you can, still have your latte or whatever your caffeinated fix is. You don't have to give it up completely. Okay, so someone else asked, what age is too old to start IVF? So that is, it is a difficult question because we do know that age is the best predictor of how you'll respond. But women, let's go back to the beginning. Women are all born with a certain number of eggs. And as we start having menstrual cycles, we have one egg a month that will ovulate, but the rest of the eggs will unfortunately go unused. And so every month this happens. It doesn't change whether you're on birth control or whether you're pregnant. There's nothing that you can do to change it. So to speed up the process of losing your eggs. So don't have to worry if you've been on birth control for years. I get that question too. I've been in birth control for a long time. Is that going to affect my fertility? And the answer is no. But what we do need to see, because women kind of lose eggs are at a different rate, we really do need to do that ovarian reserve testing to specifically answer where you're at in your reproductive lifespan. So even though I can generally speaking say that I would expect a 35-year-old to do better in IVF than a 41-year-old, I need to see what your specific ovarian reserve testing is, because you could be the 35-year-old, which unfortunately may be premature ovarian insufficiency or premature menopause runs in your family, and you might have diminished ovarian reserve even at 35. Or you could be the 39-year-old that still has very good ovarian reserve. So it really is hard to say, and it's helpful to have those ovarian reserve numbers. But I do think that once a female gets to the age of 45 or more, that is really the time when we see a very, very, very low likelihood for success with IVF. And at that point, we would probably advise, let's try a different treatment. Maybe we can get you pregnant with Clomid or IUI, because at that point, there's any advantage that was there with IVF is now gone. So I would say 45, 46 is really when we might say, really, it's not the best time to undergo IVF. Okay, so someone asked, what happens at your first appointment if it's via Zoom? I can't imagine it's much different than my appointment I had with my OBGYN, where they just asked what we've been doing. Do we even think that's necessary? Seemed like a waste of time. I want to get started sooner, and it seems it just keeps getting pushed aside. So I think that when you come to see us, we are a little bit playing catch up. Your OBGYN knows you, knows your medical history. When you come to see us for the first time, that's generally our first time meeting you. So we'll want to know about your menstrual history. We'll want to know about your OB history. Have you been pregnant before, but you had a miscarriage? We'll want to know about any other medications that you're taking, medical history, surgical history. So we go through all of those things, and then we will talk about the fertility evaluation. So what testing do we want to do? Do we think it's necessary based on the information that you've provided about yourself? And then we'll tell you, how we can get that testing done in the shortest time frame. So I think that if you have been trying, again, if I don't know your age, but if you are greater than, 35 and you've been trying for 6 months, I think it's time to come see us. If you any age and you've been trying for 12 months or close to that, I think time to come see us. If there's ever a question, just come see us. Okay, sorry, we've got some other questions. So how does insurance coverage work if we are out of state? For example, Michigan residents looking to work with your facility. So we do have out of state patients that come to see us. So we will just treat you like any other patient. So every patient before their first visit is pre-authorized. And then after the first visit, we have a financial coordinator that can go through your policy and let you know specifically what's covered and what's not covered. Some companies do cover infertility outside of, the 3 or 4 states in the United States. It's just that it's not mandated for all employers to do so in those states. So we just have to see what your specific insurance is, and then we're happy to work with you. If worse comes to worse and there's no coverage, then in your self-pay, we can work with you as well to figure out if there's grants or funds that you can apply for, or ways that we can get you medications at a discounted cost, to just anything we can do to help make it more feasible. Okay. Scrolling here. So if we are a same-sex female couple with one person carrying the baby and the other providing the egg, is IVF traditionally used on the egg donor? So I think I know what you mean by this. So if you're in a same-sex relationship and you would like to be the egg donor, so that means you would undergo IVF. If you and your partner both sign consents that you can use that embryo, then in the future, you could carry the baby, undergo a transfer, and become pregnant. Or you could be essentially the egg donor or provide the egg and do the transfer in your partner. So that's something that's called reciprocal IVF. So one partner undergoes IVF, and either person in the, that's in part of the couple could carry the baby. Can letrozole be effective without doing IUI? So the answer is yes, it can be, but studies have shown that patients who use letrozole or Clomid with timed intercourse, so trying naturally on your own, your likelihood to conceive or to get pregnant is not as high as if you combine Clomid or letrozole with IUI. So you just have a higher likelihood of success with IUI. So that's typically why we recommend it. But if you really wanted to do an ovulation induction cycle, so use Clomid or letrozole without an IUI, you certainly can. And I will say, if your infertility diagnosis is solely based on the fact that you haven't been ovulating, then that is the patient that I would say, doing Clomid or letrozole alone would give you a slightly higher chance of conceiving than those with other diagnoses of infertility. Because for you haven't probably getting pregnant because you haven't been ovulating and don't know when to time intercourse. So with letrozole, if we can help your body to ovulate, then you're automatically going to have an increased chance of conceiving. Okay, so is following a low carb or sugar diet not recommended with trying to conceive? So that is a good question. So I think the best thing to think about is everything in moderation. There has not been any particular diet that has shown that it increases, chance of pregnancy or live birth more than others. So what I tell my patients is, just try to eat a healthy diet as you would for just general health. So, lean proteins. If you're going to eat carbs, try to make them, whole grains. Lots of vegetables, fruits, try to stay away from processed foods, drink lots of water. We talked about the right amount of caffeine to drink, limit excessive alcohol use, and then also physical activity just to also just increase overall health. I think that is the diet that's best to ascribe to. There is no study has shown that if you have low carbs, that you are going to be at increased risk for conceiving. I also don't think it's not recommended either. But I think that, as I said, it's just important to do things in moderation and be mindful of what types of carbs that you're eating. Okay, so can you start with something less invasive like Clomid versus an IUI? So I think that's similar to the letrozole question, and the answer is yes. I think we just want to make sure that you're informed and you know that there might be a slight decrease in likelihood to get pregnant. But if that's something that you want to do Clomid or letrozole on their own, we can certainly help you do that. Okay, is there anything you can recommend for women over age 35 to improve their egg quality? So I think the supplement that has been shown best that may improve egg quality is CoQ enzyme 10. And so a lot of our, physicians, and not just at FCI, but in our field, will recommend that you could take CoQ enzyme 10 daily. Normally the dose is 400 milligrams, but it hasn't been proven in every study. So unfortunately, quality is not something that we really can change. It's something that we wish we could change, but it's not something, there's no magic pill to improve egg quality, unfortunately. We wish that there was. Okay, my aunt brought Clomid from Mexico. I haven't taken it, but would I be able to take it under supervision by one of your doctors to save on money? So I think that's a little bit difficult because every country has their own, rules and regulations as far as Clomid goes, and really any medication therefore. So I know I probably would really prefer if you take a, Clomid that's coming from a USA or a United States regulated pharmacy. And also Clomid is typically one of our, as far as expense goes, one of our more cost-friendly medications. So I would hope that it wouldn't be, too much for you to, purchase Clomid in a cycle, but I do think that we would prefer if you use the Clomid that we prescribed. Also, it could be expired. And I wouldn't recommend using it if it was expired as well, just because I can't tell you how effective it's going to be. Okay, after a C-section, how long do you have to wait to start fertility treatment or get pregnant? So that's a good question. So it also, something that goes into it is how many C-sections have you had? So if it's your first C-section, normally we'll like to wait from time of your delivery to time of your next delivery to be at least 18 months. So a lot of times patients will come and see us after a year, and then we can move forward with starting to get you pregnant again, because by the time you would deliver, then you would be past that 18-month mark. But it is something that we also try to communicate with your OBGYN, because they were present at your surgery and we were not. So if there was any cause for concern, they might say that they want you to wait a little bit longer, or some have even given, okay, everything looked pristine. I would be comfortable if she got pregnant in a slightly shorter time frame. So we also do communicate with your OBGYN on that, but typical is like 18 months. Okay, if I suffered from alcoholism up till 6 months ago, could it have affected my ability to conceive? My cycle has been irregular since I stopped drinking. So I think that is, first of all, I applaud you for being able to, to overcome that and to cut back on your drinking. That's wonderful. If your cycle has been irregular, it could be due to drinking. It also could be due to any, other medical problem that could have developed during that time frame. So I would encourage you to come in, to make an appointment, and let's really do fertility testing and kind of make sure that we're ruling other causes out, because it could be something else: thyroid, prolactin, PCOS. There's many other causes. What is the IUI success rate? Wonderful question. So normal likelihood to conceive in a cycle is somewhere between, 15 to 30%, depending on your age. Okay. And also, if sperm is normal. If you use Clomid with IUI, we say additionally, you have like a 10% chance of conceiving per cycle. So typically we would recommend you do 3 cycles and then come back to see us if you're not pregnant. So it'd be like a 30% chance of conceiving in that 3-month time frame. Yes, so ovulation pain, it varies. Some women don't have any symptoms around the time of ovulation. They don't even know they're ovulating. And some other women have a lot of pain around ovulation. Your pain also could be, more prominent If you have any type of ovarian cyst that's already on your ovaries, so that your ovaries are already a little bit enlarged, and then when you ovulate, it's even larger, so that can cause it's larger in your pelvis, and then it's causing more pain. So I would just say that if you're having a lot of pain around ovulation, you can use heating pad, hot showers, obviously, Tylenol, Advil is fine prior to ovulation. And then trying to conceive on peak days. So if you're using an LH kit or an ovulation predictor kit to help you time intercourse, the most likely day to conceive is the day that the test is positive. So if you're tracking, and it's negative, and then it's positive, that's the best day to conceive. It's like your warning sign that you're about to ovulate in the next 24 to 48 hours. And so the reason it's the most likely day to conceive is because sperm can be viable or live in the reproductive tract for up to 72 hours. So it's really best to kind of have it on board before you actually ovulate. So that way, when the egg gets into the fallopian tube, the sperm is kind of like sitting there and waiting for it. So best day to conceive, the day that your OPK or LH kit is positive. The next best days are the day before the kit is positive and then the day after. So that's your best 3-day window. Okay, so if I've been trying to get pregnant for 2 years, but my insurance is saying they will cover anything if I have been trying more than a year, how does that work? Do I see you for that whole year? So it sounds like for this question, that if you've been trying for a year or more, your insurance will cover any treatment. It sounds like that's what I'm hearing. So what you need to do when you come in, you can just let your physician, know that that's something that's mandated by your insurance. And basically in our note, we always started off with, X is a patient that has been trying for X amount of months or X amount of years, so that if insurance were to ever ask, it's already in our documentation and they can verify that you've been trying for that length of time so that you can get your treatment covered. Okay, another good question. How often should you engage in intercourse during ovulation? So we just talked about OPKs. And so if you're using OPKs or LH kits, they're the same thing. And I should say OPKs are ovulation predictor kits. Sorry for using that abbreviation. I will say just as a disclaimer, my recommended brand is Clear Blue Easy. You cannot often find it in a pharmacy. In a pharmacy, you're going to see Clear Blue Advanced. That is something that's more expensive. It tests multiple hormones. It's more confusing. I would go on Amazon and get Clear Blue Easy. It's just positive or negative. It's just very straightforward. So best day to conceive, the day the kid is positive, and the day before the kid is positive as the next best day. And also another next best day is the day after the kid is positive. Or if you have regular cycles, and when to expect ovulation. So let's say you have a 28-day cycle, you typically ovulate around day 14. Some will choose to have intercourse every other day between, some cycle day 10 and 20, just so that they know that they've covered themselves. Is there such a thing as too little or too much intercourse? If you have abstained for more than 5 days prior to intercourse when you're trying to conceive, there is a chance that you can have an increased amount of dead or non-motile sperm. So we typically want there to not be more than 5 days of abstinence before you're trying to have intercourse in order to conceive. And now about too much intercourse, there's been no benefit in studies to having intercourse more than once a day or every other day. So anything above that is just because you want to, not because it's increasing your chance for success. Okay, on average, how long does the IUI and IVF process take? So, all right, so you'll come in to see us, we'll start our evaluation, and it typically takes 4 to 6 weeks, just depending on where you were in your menstrual cycle when you came to see us, because some of our testing does have to be done on specific times of your menstrual cycle. So you'll come back once your testing is done. And then we typically, if we have insurance approval, can start testing within the next month. So with your next period. So that's for IUI. For IVF, it does take a little bit longer because we have to do more consents, educational material such as modules, and because your medication is coming from a specialty pharmacy. So it basically gets shipped to your house. It doesn't just come from CVS or Walgreens. So it can take a little bit longer for that medication to come in. And also depending on your ovarian reserve, your clinical circumstance, your fertility doctor might want to put you on what's called a priming medication for 2 to 4 weeks before you lead into your IVF cycle. So I would say from the time you walk in the door on your first appointment to when you can undergo IVF, it might be closer to 2 to 3 months, depending on how fast everything can get done. Okay, do women who ovulate feel differently when they are ovulating than those who have not ovulated? That is a good question, and it very much can vary. Some women never have any symptoms of ovulation, so they never know if they're ovulating or not. How you know that you've ovulated is if you're having periods. So when you have a menstrual cycle, at the beginning of your cycle, then you have tiny follicles, and then ultimately they grow, and one does, and that's the egg that ovulates. If you do not get pregnant, that is the kind of the marker that sets for your next period. So if you are, people say, well, how do I know if I'm ovulating or not? If you're having regular periods, more than likely you're ovulating, even if you're not having any symptoms of it. But that's just something that varies. Just like some women have light periods, some women have heavy, and that's normal. Some women have symptoms of ovulation and some don't, and that's normal as well. Okay, I've used Clomid. However, my progesterone levels were checked later in the cycle. It was only 3.48. What does that mean? Good question. It depends on how long after your progesterone was checked. So let's say if you had an IUI on cycle day 14, and then you came back on cycle day 21, so 7 days later, any progesterone above 3, I would consider that you ovulated. Ideally, we like to see 5, but if it's above 3, I would say that you ovulated. If you came back, only 2 or 3 days after your IUI, it could just be that you ovulated and your progesterone was on its way up. And you maybe if they would have repeated it a few days later, it could have been at 5. So that is a little bit hard to answer because I don't know exactly the days in their cycle where things were checked. But typically, in P4 or progesterone above 3, we consider that you ovulated. Okay. Let's see. Will my infertility specialist see me through the pregnancy? Good question. So as an infertility specialist, we have all kind of given up our, I don't want to say ability, because we all still remember how to deliver a baby, but our insurance only allows us to see patients through kind of the first trimester. So when you come to see us and we've helped you to conceive, we often monitor you very closely with kind of serial or multiple pregnancy hormone tests to make sure that we are watching to see if there's like the expected normal rise in the pregnancy hormone, HCG. And then you'll come in early for an early ultrasound, and then often can even have 2 or 3 before you, what we say, graduate onto your OBGYN. And then typically that occurs around 8 weeks or so that we can get you into your OBGYN's door in time for your first trimester screening, which is like a genetic test screening with an ultrasound, if you would like it. And it's typically, it has to be done at 10 to 11 weeks. So we typically want to watch you up to like that 8-week mark, but then make sure that we get you to your OB in time to have that testing done. And then they would, of course, monitor you for the rest of your pregnancy and go on to deliver your baby. But we do always appreciate, birth announcements and pictures, because we really do. We're really excited for you when we send you off, and we're sad to see you leave. Okay, so hi, thanks for this educational opportunity. You're welcome. Do the potential side effects of infertility treatment also increase with age? Good question. So typically, no. So whatever the side effects are of whatever infertility medication you're taking, it's not really going to increase with age. Only if you have certain medical conditions, maybe like high blood pressure, if you've ever had a history of a clot or a DVT, those would be things that would be more concerning to us than age by itself. Can I use my eggs and my wife's eggs with IVF? So yes, I think what you're asking is, could you potentially both undergo IVF? And yes, so you can even do it kind of in back-to-back or in close proximity to each other, and create embryos with your same, donor sperm. And then it would obviously be marked what embryos were created with your eggs and then your partners. And then moving forward, you guys could use those embryos as you see fit and as you want to. So another question about how often to have sex. So after your period, that is not the window in which you're going to conceive. So it really has to be in the middle of your cycle around ovulation. So anything before that time frame, so like while you're on your period, you're not going to conceive during that time frame. So you can have intercourse just, when you want to. It's not to help, you get pregnant. But then when you get to that ovulation window, again, you can have intercourse every other day or daily. The success rates have been the same because of that fact that sperm can live for 72 hours. So you don't necessarily have to have intercourse every other day. Or sorry, excuse me. You don't have to have intercourse every single day. It's possible to use both eggs for one pregnancy. Oh, sorry. Okay, I understand your question now. So I guess the answer to that question would probably be, it depends on age, but it would probably be no, because we like to put one embryo back at a time. So that embryo could only be created with one partner's eggs in a couple. So there would be an embryo that was created with one partner's eggs. And then typically in a subsequent pregnancy, we could place an embryo that was placed in with another partner's eggs. I hope that is more clear and answers your question. Okay. And that is because of the risk of multiple pregnancies. It's always safer to carry one child at a time, or to have one baby at a time for both baby and mom. And so that's why it's the one embryo transfer, especially, but it does a little bit depend on age, but especially if you are less than 39, the recommendation for first transfer is going to be one embryo. Okay, so this patient or this person asked, if I'm 36 and have never had any issues known to me with my reproduction, I have gotten pregnant at 20. What chances do I have to get pregnant naturally if all tests are done and there's no issues? So I would say if you have normal ovarian reserve, then you have the same likelihood to conceive as any other 36-year-old. And I would say your chances per cycle are probably somewhere around 20 to 25%, maybe more like 20%. And that's the same as any 36-year-old. So if you've been trying for 6 months or more and haven't gotten pregnant, then you should come to see us. There's, as I said, even if all testing is normal, we know that we still have a lot to learn about fertility and causes of infertility, and there's still treatments that we can recommend to help you conceive. Okay, so someone asked, since embryonic testing takes about 2 weeks for the results, so we're talking about pre-implantation genetic testing, or you might see it abbreviated PGT, and the embryos are frozen during that time period, does embryonic testing potentially lower the chance of success in vitro fertilization, as thawing the frozen embryo can be a factor in vitro fertilization? Please correct me if I'm wrong with this thing. Sure. So we have seen similar pregnancy success rates with frozen embryo transfer compared to fresh. So if you are doing IVF and then you have a transfer right away, that's a fresh transfer, as opposed to you do IVF and then you take a little break, you have a period, and then we, either go with your ovulation to transfer or do what's called a programmed transfer cycle. We see similar success rates, maybe even a little higher with frozen embryo transfer, depending on the circumstances. So your ovarian reserve and your age, also your lining. Those are all important factors. The freezing of the embryo, that is something we've tried to look into. Does freezing of the embryo impact the embryo itself? From what we've seen in studies, we don't really think so, that it negatively impacts the success. However, we do think it's ideal to freeze the embryo once, as opposed to freezing it, thawing it, so warming it back up, and then freezing it again. So multiple cycles of freezing, we try to, avoid if possible. Now, sometimes it's necessary if you have a frozen embryo and then you decide to biopsy it or do PGT testing down the road. So if it does affect it, it's not a large amount. We're still trying to get studies to really learn exactly how it impacts the embryo, but we do not think freezing in and of itself is detrimental as far as likelihood for success. What can you do to help low dead sperm count? So good question. It could just be that the abstinence period is too long. So if you came in if a partner came in for a semen analysis and he had not ejaculated in some way, shape, or form for more than 5 days, my recommendation would be, let's try a shorter time frame of abstinence to see if that changes it. He can also, I would recommend a multivitamin, CoQ enzyme 10, healthy diet, kind of similar things I would tell a female partner. If you're a tobacco smoker, let's stop smoking or quit smoking. Let's have moderate alcohol intake. So those are the things that I would, try and see if they could possibly help. Is there an ideal TSH for getting pregnant? That is an excellent question. So TSH and 3T4, so thyroid issues, we know can impact likelihood to conceive and also can impact risk for miscarriage. So your primary care or for general health, the recommendation typically is that a TSH is normal if it's less than 4 to 4.5, depending on the lab. For reproductive health, we have stricter or tighter controls. We like to see your TSH less than 2.5. So if you fall between the 2.5 and 4.5, we will typically recommend that you start medication, and that's called subclinical hypothyroidism. If your TSH is greater than 4.5, then your primary care doctor, when they saw you, would have also recommended that you start medication because you would have overt hypothyroidism. So that is a good question, and we do have kind of tighter restrictions on TSH. Can low sperm motility be fixed? So similar to the question about dead sperm, we would advise to try multivitamin, CoQ enzyme 10, see if that helps. We do have also a fertility specialist on board now, Dr. Olander, who's a male urologist, so trained in urology, but then did a fertility fellowship or training as well, and he has been a great asset. So we can pull him in to see is there anything else that he would recommend. But also, if there's immotile or non-motile sperm, a kind of a definite treatment for that is IVF, because in IVF, with ICSI, we directly inject the sperm into the egg. And so therefore we don't need the sperm to move. So we kind of are overcoming poor motility. I took Clomid day 5 of my cycle, but my menstrual continued for another 5 days. Does this lessen the likelihood of it helping with ovulation? So it does not. So what's going on as far as bleeding is really confined to your uterus. Clomid is really working directly on your ovary. That's what we're looking at for it in order for it to grow follicles. Now, what we do want to make sure is that we've given your lining a chance to kind of thicken or be prepared to hopefully be a good landing spot for an embryo. So that is something that we would have to look at. And if your lining was thin, then there's additional medications that maybe your doctor would recommend, such as estrase, vaginal estrase, to try to increase your lining, or might recommend, if the lining's really poor, that maybe let's kind of see what's going on with your period and maybe try again that cycle. So it really kind of depends on what your lining looked like. Okay, I think we have time for one more question. Does abnormal sperm morphology pose any miscarriage risk, or even worse, increased risk for birth defects? That's a good question. There's a lot of research going on in that area. Right now, we, don't have enough information to say it's causal, meaning that abnormal sperm shape causes miscarriage, but it's something that we are, looking more into. Okay. Well, I just want to say thank you so much for joining me, and I hope this was helpful. Thank you for kind of just giving up, your time to listen in. And please, please, please don't hesitate to come see us so we can answer more of these questions in person. This webinar will be, it was recorded and it will be posted on our website, but please feel free to kind of just find us on fcionline.com. That phone number to make an appointment is listed there for our new patient call center. And also this webinar will be up there so that in case you want to watch it again, or you want your partner to watch it with you, or maybe someone that just needs to, really hear this. So I just want to thank you all again for joining me. And if you guys need a fertility physician, I'm here for you. So please don't hesitate to come and see us. Thanks, everyone. Take care. Be safe.